So this session is session 4. We're talking about the latest research findings in hypothalamic pituitary brain tumors. And this is always a popular session, and we're happy to have Dr. Shana McCormack back with us again this year. And Dr. McCormack is an attending physician in the Division of Endocrinology and Diabetes and an assistant professor of pediatrics at the Perelman School of Medicine at the University of Pennsylvania. She cares for children with pediatric endocrine disease. She has a clinical interest in patients with endocrine dysfunction related to individually rare metabolic disorders such as primary mitochondrial disease, Friedreich ataxia, and lipodystrophy. She also has an interest in inherited and acquired forms of hypothalamic and pituitary dysfunction, in particular those associated with abnormal energy balance and obesity like craniopharyngiomas. As a physician scientist, she investigates the neuroendocrine systems that regulate energy balance in humans. We are also honored to have Dr. McCormack as a member of the Raymond A. Wood Foundation Scientific Advisory Board. Dr. McCormack?
Oh, thank you so much. And thank you for the kind introduction. And I am officially sharing my screen. Amy, does that look okay to you?
Yes, I see it. Good.
Awesome. Well, thank you so much again to Amy and her colleagues for inviting me to do this again. This is, I hesitate to make it a superlative, but I will. I think one of my favorite talks that I give, because I have the opportunity to go through the literature and think about what might be most relevant to you, to the folks most impacted by hypothalamic and pituitary tumors. Here are some of my disclosures with respect to industry-supported research. And I'm starting with my gratitude slide. Again, thanks to Amy and the rest of the Wood Foundation, the Chang family and the Finnemore families, and many other families who support the Neuroendocrine Center. I won't read through the names of all of our collaborators, but all of the work that we do in our center and the research that we do is multidisciplinary and is the work of a lot of people. I will thank all of you all for taking time out of your Saturday to attend, because we learn so much from your interests and your questions. So thank you for those. As Jamie mentioned, I think the last 10 minutes of the session are devoted to questions, and anything we don't get to, we have a panel at the end of the day as well. So an outline with respect to considerations for today's talk. My interest is in neuroendocrinology. Of course, I'm going to focus on neuroendocrine studies. This is certainly not a comprehensive talk. There are way more articles that ended up on the cutting room floor that I couldn't review, but that are super. I am intending to add and complement to what our terrific keynote speakers presented earlier. For folks who are just in Craig's talk about doing your own research about finding articles and abstracts on PubMed, you'll see that every article I review today, I share the PMID, the PubMed ID. So if you go into PubMed with that number, you can look up the article. And Craig mentioned some of the articles are behind a firewall, so we might have to pay for them. But more and more, our research funding organizations require us to make articles open access, meaning you can access the entire text. And also a standing offer, any studies that you find at the end of each of these sessions, I make the new folder for next year. Even if I don't end up giving this talk, it's a really fun thing to receive studies from folks who share them. So please feel free to keep doing that. And my contact information I'll share at the end of the talk. All right, so updates for 2022. I've divided these into topics that you might find interesting. A few of the papers that we're going to talk about today, including one of the first papers that I think is most interesting, is related. It comes from survey data from patients and families. So Amy, I think, is going to launch a poll question related to surveys. Let's see how that goes. Awesome. So the question, I'm going to read it.
So bear with me 1 second.
Oh, okay. I see the question.
Oh, you do? Okay, hold on.
Now it just went away.
Okay. Hang on. Let's try this again. Oh,
there it is. There it is. Yep. I see it. So it says, have you ever taken a survey about your experience as an individual with a brain tumor or as a caregiver or family member? And I put, you shouldn't count this one because this is new, but I'm curious if folks have yes or no. So what do
I'm
you
not
think?
sure. I think I ended the poll. Let me just try this again. Let's relaunch. Okay. Now we got it.
There
Okay.
you go.
Sorry about that.
Same question, so folks can go ahead and answer. And then Amy, you'll show the results when they come.
Yes, let's give them
Cool.
a minutes. We've got 73 participants. So I'll give everyone a couple more seconds.
Very cool. Yeah, so while folks are filling these in, the surveys that that people send out to patients and families are really the source of a lot of really rich data, and at least 2 of the studies that I'm going to be presenting today come from survey data. So I'm curious how many folks have been reached by surveys. And Amy and the Raymond Wood Foundation have been really pivotal in getting those surveys to the right audience.
We have 63% yes, 33% no, and 4% not sure.
Cool. So that's 2/3 yes. Awesome. Awesome. Okay. So with that in mind, I'm going to get, oh, there you go.
Yeah, sorry. There you go.
There you go. I see the result. Very cool. So the first topic is diabetes insipidus. And the first study that I'm going to share is from a really impressive survey of folks with diabetes insipidus. So this is from a study. Senior author is Miriam Chris Crane, and Sihan Attila led this as a European group. Central diabetes insipidus from a patient's perspective, management, psychological comorbidities, and renaming of the condition, results from an international survey. So their group surveyed more than 1,000 individuals who had DI. A minority, 9% were kids, 91% were adults, and of the adults, there's a female predominance to the respondents. Of interest for this group, Miriam took all comers with diabetes insipidus. So there's lots of different reasons that folks can have diabetes insipidus. I think we can learn from this experience. Tumors or cysts were the single largest cause, but there were other causes represented as well. So here I'm going to show you some of the findings from this survey. And by the way, this is the format I've taken for these talks in the past, just kind of give you some brief vignettes of what I think are some of the most interesting articles we've seen. So the figure you see on the right is a bar graph that shows how DI is managed by the different individuals who responded. So a little over half, 56%, took oral tablets, around a quarter took nasal spray, 12% take the sublingual tablets that are much more readily available in Europe. 4% take no medication, 3% take a combination, subcutaneous injection, and rhinal tube were the minority. So it was really striking that a quarter of individuals on DDAVP had hyponatremia requiring hospitalization. And I think one of the question askers in one of the earlier sessions had talked about sodium abnormalities. So this is I'm talking about a burden in these individuals. It's pretty substantial. And what they found was that folks who had regular aquaresis, I'm going to say what that is in just one second, were hospitalized less often, 22%, as compared to those who did not, 34%. So aquaresis is just getting rid of water. So folks who have DI with intact thirst, we can talk about those without intact thirst in just a second, but for folks with intact thirst, as endocrinologists, we often recommend that if they don't break through, if their DDAVP doesn't wear off once a day, which it does for many people, to the point where they're peeing more and they're getting thirsty, if that doesn't happen on most days, that perhaps one day a week, they delay a dose in order to have the pee come off and to get a little thirsty. And that's one mechanism in folks with intact thirst to protect against hyponatremia. So the authors of this particular study suggested that folks review that with their endocrinologists. For those who have intact thirst, that's a pretty reasonable strategy. Those without could be the topic of a whole nother talk, but something important to bear in mind, that risk of hyponatremia. This next bullet point was also really striking and really disappointing to me, truthfully, as a member of the medical community. 13% had dehydration when they were in the hospital with DI related to missed or delayed doses of DDAVP, meaning the DDAVP wasn't given as it should have been, and so folks got dehydrated. So we work on this at our hospital by making sure everyone has standing orders for DDAVP and an available as needed order that makes it physically available on the floor, so you don't have to call the pharmacy to get it, which can lead to a delay, but something really important for us to bear in mind clinically. This is another really striking point. So 80% of the respondents had one occasion of diabetes insipidus versus diabetes mellitus confusion. Now, this group is very well informed as to the difference, but as you know, diabetes insipidus, right? Deficiency of the vasopressin hormone. Diabetes mellitus, which is blood sugar diabetes, both have diabetes in the name because they're both named for conditions that cause you to pee a lot. But especially in adults where, folks see diabetes in the chart, they may not read that second I, and folks get, for example, prescribed insulin that they might not need, and that could lead to low blood sugars. So it's a really big deal, and the rate of confusion is striking. Perhaps not surprising to this group as well, 2/3 of respondents reported that their quality of life was affected by their diabetes insipidus, and fully 1/3 also reported psychological changes that our colleagues in neuropsychology may be related to the areas of the brain that are impacted that cause both DI and have important role in psychosocial function. So really rich survey data and lots of important points. One of which, I'm showing this slide from the European Society for Endocrinology that has the icon for a campaign with which you may be familiar called No Need to Die, No Need to DI, related to the potential need to rename diabetes insipidus, because especially on the adult side, the rate of confusion between diabetes mellitus, blood sugar diabetes, and diabetes insipidus is really problematic. And would calling this something different, would that be helpful in avoiding these problems? So what does the proposed change name look like? So this is a position statement on what the name should be that's been evaluated by the Endocrine Society, which is the society that we belong to in the US. Also, I think up for review in the Pediatric Endocrine Society shortly. The old name, diabetes insipidus, central diabetes insipidus for folks who have diabetes insipidus because of vasopressin deficiency from the hypothalamus and pituitary. The proposed new name is arginine vasopressin, which is the hormone that's missing, deficiency for central causes, meaning when they come from the brain, and arginine vasopressin resistance for nephrogenic causes, which is a kind of diabetes insipidus that happens because the hormone doesn't work well at the level of the kidney. The rationale, as I mentioned, is that name diabetes could be confusing and harmful. And the investigators asked the respondents, like, what do you think? Should we change this name? And that name change was favored by 85% of the survey respondents. And as I mentioned, north of 80% had related errors or confusion in their care as a result. So AVPD is what we're supposed to call it. They're even submitting, this group, a proposal to the ICD, the International Classification of Diseases. Those are the diagnostic codes that we write at the end, we type them these days at the end of visits to say, these are the diagnoses that these patients have, to change it so that in our medical record it will be different. They propose that for the near term, over the next several years, once this name change is adopted, that when we say AVPD, we put central diabetes insipidus in parentheses. So during the transition, folks know what's going on. So I first want to ask the group what they think about this name change. I have a feeling I might know the answer, but I'm curious if your responses will be similar to what was found in the European study. So Amy, are you able to put this one up? Awesome. So the question is, do you support renaming central DI to AVPD? And the answer choice is yes, no, or not sure. So while Amy is accruing the answers, I said I'm going to try for the rest of the talk to use the new nomenclature. So we'll see how it goes. It's going to be a tough habit to break.
Yeah, so it looks like we have 80% participation. I'll give everyone a couple more seconds. If you don't see the questions, a lot of times it's because you may not have the latest version of Zoom. So sometimes the polls don't show up. I'm going to end it right now. Oh, we got a few more. Okay. So do you see that, Shana?
I don't see the results.
Oh,
but
let me
that-
share.
Oh,
There
there
we
it is. Yep. So look at that. This is the similar proportions as the survey. So we had 83% in favor, 10% no, and 7% not sure. So when we get to Q&A at the end, I'll be curious for the no's, how they're thinking about it, because I want us to weigh in thoughtfully on this issue going forward. So next, AVPD, in parentheses, central diabetes insipidus related paper that I pulled for the group was about venous thromboembolisms, or VTE, which is the fancy word for blood clot, that occurs more often in both pediatric and adult AVP deficiency. So I have seen this in my practice before, and this is a case report. The senior author is our colleagues from Connecticut Children's. They reviewed 2 patient cases and went through the literature. So they described the case of a 10-year-old boy whose MRI images are shown here on the right, initially presented with headaches and vomiting, and had the MRI you see in panel A, which shows this is the craniopharyngioma in the middle, and had near total resection, which you can see in the follow-up MRI, and was unfortunately readmitted with post-surgical AVP deficiency and had a high sodium, suggestive of dehydration. Then the individual had a cardiac event and was found to have a pulmonary embolus and a DVT, a blood clot that forms in the legs. And the pulmonary embolus was what happens, and it's shown in the echo, when the blood clot from that leg travels through the heart to the lungs and can make it difficult to breathe and can even compromise cardiac function. So it's important to know that untreated AVP deficiency can predispose to blood clots. And I put the table here. There's the PubMed ID, but for myself, truthfully, and for any of those who are interested about the recommendations that this group makes based on this insight. First is to educate about the risks and be vigilant, which I hope sharing some of this accomplishes. Controlling the AVP deficiency, considering clot prophylaxis if someone's hospitalized and is at risk. And where possible, mitigating risk, meaning decreasing blood clot risk, would be helpful. And of course, you say, well, Shana, it would be great if obesity weren't a big problem. And there's a whole section of the talk on that. Being thoughtful about estrogen dosing. We always pay attention to not too little, but also not too much. And of course, managing infection, avoiding lines where they don't need to be, other kind of steps that we can take. Oh, look, Amy, I already messed it up once. Diabetes insipidus peri-procedural management. In my defense, this is from the websites that I pulled it from, diabetes insipidus or AVP deficiency. I saw in one of the earlier talks, folks had questions about protocols that doctors use. These ones are in the hospital. For management around operations, how should diabetes insipidus be managed? These are obviously small type. They're not intended for you to read them in detail, but maybe to mention that for folks who are potentially going to be undergoing either pituitary operation or any kind of operation, the panel on the left is from CHOP, the panel on the right is from Seattle Children's. We have all published guidelines in collaboration with our anesthesia colleagues on how diabetes insipidus, AVP deficiency, can be managed to reduce complications in the hospital. So these are guidelines, they're a starting place, but they're certainly better than nothing for folks that might be unfamiliar. And if you're interested in how we think about this, and when we have a patient going to the OR, I invite you to check out some of those resources. All right, so we don't have tons of time, so we're going through the hormones quickly. Next hormone is growth hormone. So I'm sharing with you a recently published consensus statement. So these are really important to me when we see them. It means there's been an effort to pull together expert opinion to give guidance that hopefully is more rigorously supported by evidence, by literature, or at least represents what all of us think is the best approach. So we know that growth hormone, of course, helps children grow who are missing it, and folks with hypothalamic pituitary tumors may be missing it more often. It also has benefits beyond growth that we study. Dr. Crowley, who presented to you earlier, is also focusing on some of these potential benefits for body composition and quality of life. There has been hesitation about using growth hormone in survivors of cancer and survivors of brain tumor based on a theoretical risk without evidence, but I'll describe the theoretical risk that essentially if growth hormone can make healthy tissue grow, could it also make unhealthy tissue grow? Could it also make tumor tissue recur? And of course, that's an important consideration. So far, thank goodness, the epidemiologic literature, meaning our experience, doesn't suggest that starting growth hormone increases the risk for cancer or for recurrence. But we continue to study this in detail. And so this is a consensus statement that speaks to the most appropriate timing and use and growth in survivors of childhood cancer, including individuals with hypothalamic pituitary tumors. So really the question often ends up being kind of when to start growth hormone, like when is it appropriate? Well, certainly you have to have evidence that growth hormone is deficient, right? So declining growth velocity might be one piece of evidence, or there might be stimulation testing or other testing done that suggests growth hormone deficiency. And then our practice at CHOP, and I know in other institutions as well, is to talk closely with our neuro-oncology colleagues about whether or not it's appropriate to start. And notable for this group, this consensus statement suggests that we can start as early as 3 months after resection in individuals, for example, with craniopharyngioma and radiologically stable disease, meaning no evidence of recurrence. For other tumors, for other hypothalamic pituitary tumors, it's suggested that one wait at least 12 months. The reason for that is that the most recurrences for some of these other kinds of tumors occur within that first 12 months after initial treatment. But over time, this consensus statement represents our kind of timing for starting, getting closer and closer and closer to diagnosis as our evidence of safety accumulates and of benefit accumulates as well. So this is potentially a conversation starter for folks if you're, for example, facing this decision about when to start growth hormone to bring back to your team. Also, I'll point you to, and I think the Raymond A. Wood folks were going to put the link in the chat. Lori Cohen, formerly with Boston Children's, now division chief over at Children's Hospital at Montefiore, who was a clinical mentor of mine going through when I was a fellow at Boston Children's, just amazing, knows a ton about growth hormone. And for folks who really want a deep dive, there was a really terrific learning seminar that you can still access, which is awesome. More on guidelines. So I talked to you about a growth hormone safety use consensus guideline. This is another set of guidelines. This is a big year for guidelines. Hypothalamic, pituitary, and other endocrine surveillance among childhood cancer survivors, and this includes individuals with brain tumors. So what this represents is the incredible effort, 42 faculty as part of this work, the International Late Effects of Childhood Cancer Guideline Harmonization Group. And the goal of this was to harmonize recommendations, meaning there's different guidelines in different places, right? About, for example, growth hormone, about when folks should go to subspecialty care. Other guidelines available from this group are relate to ovarian function, to fertility, thyroid cancer risk. Like, can we pull everything that's been done that's relevant and also add the most recent evidence that we have? So this is a really nice schematic that I've pulled from the article that you can look at, but essentially it invites us to, as clinicians, right, to look at the risk for hypothalamic dysfunction, talk about when to screen. Of course, for folks who have tumors that affect the CNS, then and the hypothalamus and the pituitary, then endocrine evaluation is appropriate at diagnosis. But it speaks to how often to follow up. For example, at least every 6 months before puberty and at least yearly after puberty. This one is really nice. When could you stop looking if you had a hypothalamic pituitary tumor, but were blessed with not to have any issues related to it? And they suggest after around 15 years. The article also reviews how we screen for problems, including physical exam, a lot of discussion earlier about laboratory studies and lab monitoring that we do for different hormone deficiencies, and then particularly worrisome signs that might prompt you to refer to endocrine sooner or in between scheduled visits, including decrease in growth or absent puberty development or any worrisome symptoms. So I'm summarizing what is a many page document. again, that for folks who have an interest and would like to read, it's available, or if you're in an area where your clinician may be less familiar, this is a great place to have a guidance all in one place. I'm going to switch gears and talk a little bit about imaging. This study, I think, is interesting, not necessarily because what it says itself, but what it says about the direction that our amazing radiology colleagues are going in evaluating individuals with hypothalamic pituitary brain tumors. So we have colleagues at Penn who are working on this. It's just so exciting to hear what they're doing. This is a group from Korea, not our folks from Penn, but I could have easily chosen one of their articles. So computational neuroradiology is the name of this field that offers insights to brain tumor care as part of precision medicine. So, for me as someone who has an interest in metabolism, we know that it's really helpful to understand the extent of hypothalamic injury. And Christian Roth and Francisco Perez, when they presented to this group before, talked about some of the work they've done in Seattle with quantifying hypothalamic injury via MRI. This group was looking at more automated techniques to really drill down and how could we measure very precisely the volume of the hypothalamus that's remaining in folks who've had craniopharyngioma and treatment, and use that to help with prognosis and to develop precision interventions for different people. So what they did was take MRIs from 78 adults with adult onset craniopharyngioma who were treated with surgical resection. And then they evaluated T1 and T2 based MRI techniques. And you'd say, what's the difference? And I'm not a neuroradiologist, so I'll just give you the very easiest difference, which is there are different ways of taking the MRI scan. T2, cerebrospinal fluid, is white, and T1 is black. So you can see which ones are which. And this is a slice through the brain like this. And the red areas, the red triangles, are where the machine algorithms have attempted to quantify the volume of the hypothalamus. And the investigators concluded it was easier to do in the T2 based technique, which is technically interesting for them. But for me as a clinician, what was interesting was that the volume of the hypothalamus that they were able to measure using these automated techniques was correlated with the individual's body weight, both before and after the procedure, in the direction that having, kind of what you'd expect, but having more remaining healthy hypothalamus was better with respect to avoiding hypothalamic obesity. Interestingly, in this series, there wasn't a whole lot of weight gain after the procedure. Many of the individuals had already had evidence of hypothalamic injury and gain from the tumor itself. So really this pre-procedure MRI was very interesting or informative to say that a lot of the excess weight gain seemed to be related to that hypothalamic damage. So speaking of hypothalamic obesity, I know this is always a really interesting topic, so I'm going to switch gears to this section. Another survey. So this is a survey, Julia, who presented to you earlier, and Megan Craven, another one of our trainees, put this together. Cassie Klein and Fatima were involved as well, and Matt Hawking from our neuropsych team, and Lucas Chang as well was a contributor. So a nice group. We had put a survey together because between Cassie and Fatima and Matt and myself, Julia, all planning different studies related to hypothalamic obesity. The Raymond A. Wood Foundation was kind enough to help us get a sense of taking the community's temperature, if you will, with respect to their needs. We did not design this survey to be something that later turned into a paper, but we had so much interesting data that we got back, and folks were kind enough to spend time filling it out that we decided to put it together and publish it. And this is open access, I believe, so you could go back and kind of read all the detail that you might want. So it was a web-based survey of adult caregivers of children with craniopharyngioma. It was completed right around the beginning of the pandemic. 79% of individuals who had the craniopharyngioma had DI, and 57% were affected by obesity. And that's notable because this is a survey that was administered, of course, after folks had already been diagnosed and treated. Excuse me, but that's in comparison to 6% who reported having had obesity before the diagnosis. So I'm going to share a little bit of our survey findings. Some of the strengths, I think, of the survey were that we were able to distribute it widely thanks to the Wood Foundation's web-based presence. That's also potential limitation because we didn't track individual folks down and, for example, verify medical records to make sure we had accurate information. We also know that folks who respond to surveys may be those who are more motivated by the concerns that they have. So, a different approach than, for example, trying to survey all the people who come to CHOP, some of whom may not be inclined to complete a survey or take the time. So whenever we get data, we interpret what we get just in the context of how we did the study. So hypothalamic obesity is something that's of interest to us. So we were curious to know in individuals with obesity and individuals without obesity, what kinds of interventions had they tried to manage their obesity, and did they find it helpful? And we didn't try to define helpful for people. So helpful could have been like, maybe it helped a little versus like life-changing. We didn't attempt to differentiate between those two, but perhaps in follow-up, we could consider this. So one thing that struck me about these data, and I'm glad that Megan and Julia decided to analyze and put the kind of folks with and without obesity side to side, because it highlights that even individuals without obesity may be trying or working with many of these strategies because perhaps they have a lesser degree of hypothalamic injury and or with substantial effort, they may not have obesity at the moment, but for some of these interventions, perhaps they would, right? So that was one interesting finding. We found, not surprisingly, most individuals with obesity had tried some kind of dietary intervention, mostly limiting carbohydrates, of which many found it was helpful, but of course we don't know exactly how helpful, right? Similar thing was true of exercise. It also struck us that a minority had been offered or had tried medications. Since this is a really challenging condition, one might have imagined that medications would have been tried more often. I'll mention this survey was done before some other obesity-related medicines were approved in children and adolescents, so we might get a different response now than we did then. And we actually have one of our fellows looking into this question, what's happening with more recently approved obesity medicines in our patients with hypothalamic obesity. But we know there's still a lot of room to go because there's only fewer than half thought that any of those medicines that they tried were really helpful in any way. The other finding that I thought was really interesting, we also surveyed folks about social function. And we administered a validated instrument that gets scored to their parents, where there's a score for the average for the population that's 50 for like kind of the average child, with a standard deviation above or below the mean of 10. So remember, standard deviations from high school statistics, like 2 above and 2 below is kind of the typical range. And where a higher score is better with respect to peer relationships and social function. And what we found is individuals either without or with obesity had scores that were below that population reference of 50. And for folks with obesity, it was even lower. So people have told us this, and it is nice. I wish we didn't have this data to point to, but when we go, for example, to study this or to our funding agencies and say, this is a really big problem and we need to address it, we have published data now that can attempt to start getting at the scope of the problem and motivate the studies that are ongoing now to figure out more about why this is happening. I'm mindful of the time. I'm going to keep going through hypothalamic obesity. So this is a study from Haneke Van Santen's group, also in Europe, on dextroamphetamine, on stimulant use in hypothalamic obesity. I'm presenting it for 2 reasons. One, because of the substance, because it might give folks an idea about stimulant use if they haven't considered it. And also because the way they present the data, I think, is really helpful as you see more and more clinical trial data coming out to kind of introduce you to how it's presented if you're not familiar. So they included 19 individuals with some hypothalamic form of obesity, either acquired or congenital. I focused on the 11 there's 11 with tumor-related hypothalamic obesity. They were less than 11 at the age of tumor diagnosis and somewhere between 7 and 15 when they got stimulants. The amount of dextroamphetamine, which is a stimulant medicine that was used, ranged between 5 and 35 milligrams in total for a day. The details are really nicely written out in the paper for clinicians who might choose to learn from their experience. These are 3 growth charts from individuals, and I think You're probably used to seeing growth charts if you report it, but so helpful to see kind of different patients respond differently. There's lots of heterogeneity, as Cassie Klein earlier today and Todd mentioned in this condition. So the red arrows are at diagnosis, and this individual, for example, all of these were individuals with brain tumor related obesity. This was the BMI trajectory, and this green arrow is when the stimulant was started. So some response. This green arrow is when the stimulant was started, a more brisk response, you might see, right? And then in this individual, the blue arrow is exenatide, an earlier generation GLP-1 receptor agonist. Not much happening there. So they started the green arrow, the stimulant, and really not much happening there either. So this illustrates that there's a range of responses in different folks. This is what's called a waterfall plot. That's where each person gets a line on the graph, and we show the range of responses that way. And the number here, this is 0, is the change in BMI standard deviation score. So green is they lost weight, blue is it stayed the same, and red is it went up. So you can see the range of response represented. Another clinical trial follow-up paper that was published this year, Christian Roth has presented to this group before about exenatide, which is a earlier generation once weekly injection, a GLP-1 receptor agonist for in a study that they did for 36 weeks. In that study, body mass index did not change substantially, but fat mass did, in that there was less of a gain in fat mass in folks who were on the treatment. We could spend like a whole session discussing that study. It was really fascinating. But this follow-up paper that Ashley Shoemaker is the lead author on from Vanderbilt, that exenatide did lead to a decrease in food intake for those who were treated with it. So that's a really important insight. So for some folks, they were able to eat less. What was super interesting to me that kind of points to something that we're going to have to address in the future is that treatment led to a decrease in total energy expenditure. So folks with hypothalamic obesity may already have a lower metabolic rate, a lower amount of energy that they use, but even accounting for body composition, even accounting for the change in fat mass and lean mass, the medication itself seemed to also lead to less energy expenditure. So even though it produced some modest benefit, this finding suggests that it may be challenging to maintain weight loss in these individuals and may give us even more of a clue as we go forward and find treatments that work. We'll think about, well, how easy or difficult is it going to be to sustain those treatments? And so this is, I think, is going to be a really important area for us to follow going forward. I have just a few more slides before we get to our Q&A. This is clinicaltrials.gov. This is where we are all in the US required to register our clinical trial. So Todd Hankinson from Colorado showed this to you earlier. I'm showing it to you because I'm going to share very briefly the top line studies of setmelanotide, the injectable melanocortin 4 receptor agonist. I think Amy's going to show more from the Rhythm folks who did this study at the end of my talk, but just the kind of top line. This is clinicaltrials.gov. This is where you can find information about any trial. And this trial enrolled 18 individuals. It was open label, meaning there was no placebo. They just took folks and treated them. It was a phase 2 study gaining some initial experience about safety and efficacy. And it was 20 weeks long. And this is from Rhythm's website, which you can check out yourself if you like, but 16 out of 18 participants had a decrease of 5% or more at 16 weeks. And the response seemed to be sustained at 41 weeks. So this is pretty impressive data for folks who are familiar with this condition. And a phase 3 trial is planned, which will be randomized and placebo-controlled pre-registration for early 2023 that importantly goes down to age 4. So for sure, watch this space, and Amy will show you more. I'm going to go very quickly through the last couple of slides. This is an important paper from the folks at St. Jude's. Kiri Ness is the lead author. They followed 94 children with craniopharyngioma at annual intervals and evaluated their physical function related to healthy age and sex reference cohorts. And what they found, and this chart shows people who were impaired, meaning had low function at baseline versus didn't. and what happened to them over time. Did they get better? Did they get worse? Like, which direction, where did they start and where did they go? And we could spend a lot of time on this, but grip strength came up in earlier for Julia. Knee extension is another aspect of physical function that they followed. And I'll have you focus on knee extension because to me, it's their biggest finding. They found a huge proportion of individuals, this gray bar, were impaired at 2 years out and continued to be impaired. And then even, more people went from that not impaired to impaired category. And I think this, where this comes from, like why folks are either don't have great physical function to begin with or are losing it, I think it has health implications and functional implications that we work with Kiri on another exercise related study in cancer survivors. And I think that will be really important to extend to brain tumor survivors too. Our last study from St. Jude looked at 80 youth and measured sleep. And very briefly, I'll show you, they found several different groups. They did a technique that kind of groups the data for you when you've measured something of interest, and here what was of interest was sleep quality. So they found that some folks are healthy sleepers, around 2/3, but a substantial proportion were either night wakers or delayed sleepers. And so what's the difference? So delayed sleepers, that's this dashed line. This is a figure called sleep onset latency, meaning how long does it take you from when your head hits the pillow to when you fall asleep? And the healthy sleepers, that's like somewhere between 15 and 30 minutes. The night wakers between 30 and 45. These delayed sleepers, somewhere 90 to 105 minutes on average. So that's substantial. And then the next category they looked at was wake after sleep onset. That's like how long are you awake after you fell asleep the first time? And as it might make sense, the night wakers, these folks who fall asleep but then wake up later in the night, were also awake for like between 90 and 100 minutes a night, so substantial. And this was, of course, associated with excess daytime fatigue and other issues. You know what, Amy, in the interest of time, I'm going to skip this research poll question, but I'm just going to ooh, what?
Well, I was just going to say, we don't have a lot of questions in chat and we can probably shift them over to the panel. So
that's what I was thinking. Okay, so we can, yeah, let's do it then. Let's do this poll question about research, because I'm just going to share with you one other research option at CHOP for folks who might be interested. Okay, so the question here is, have you ever considered participating in a research study? This doesn't mean you've done it. It means you like thought about it. Like you saw one and you're like, oh, that me or my child might be eligible for this. Maybe I'll do it. And I'm curious what people will say, because I know, certainly we know that many people have participated in research studies, but I am guessing many, many more consider it than ever participate.
And just a reminder, there you should see a poll window in your screen. If you don't, it just might be the version of Zoom. We have about 67%
who have considered it,
or know that have participated.
Oh, okay.
For seconds. All right, and then I'm going to share the results. There you go.
Oh yeah, so this is great. So 92% of people have considered participating in the study. And Amy, I didn't do the follow-up, which is like, and how many of you actually did it? But the reason I asked the question this way, the reason I said, have you ever considered, is because I get the sense there may be folks who think about it, but they're like, I'm not sure about this potential side effect of the investigational drug, for example, or I'm not sure how I would juggle travel to the research site. And so for some people that may deter them from even reaching out. But for our group, and I'm confident for my colleagues as well, like we welcome inquiries from folks who think they may even want to, because we're often able to answer some of the questions that might encourage folks to participate, or even if they don't want to, and if they're like, you know what, I got this information and I still don't want to, it's very helpful for us as investigators to learn, like, hey, what are the barriers for people to participate? And either for this study or for future studies, can we think of ways to overcome them? So our goal, big picture, is to make life better for people with these conditions. And so we learn from absolutely every interaction we have. So if you've considered it and it's even on your radar as something you might do, feel free to reach out to the study team. And with that, I'm going to mention one other study opportunity that that didn't get presented earlier in the day that's at CHOP, that's led by Matt Hocking. Peter Fantozzi is the coordinator. His email address is listed there and study phone is listed there. This is an NIH National Institute of Health funded study on social connectedness in survivors of pediatric brain tumors. Folks come to 3 different visits at CHOP over the course of a couple of years. And Matt's goal is really to understand what are all the different factors that affect social connectedness. And I'm grateful to be a part of this study to kind of look at the neuroendocrine contributors. Our colleagues at the Autism Center are helping understand, using really some amazing techniques to understand how people really drill down on how people do interact with each other. So folks who are eligible will be children between the ages of 8 and 16 and have been diagnosed with either medulloblastoma, cranio, or pilocytic astrocytoma and be at least a year out from treatment.
Hi.
Awesome.
Thank you so much for all of this great information. And it's so encouraging to see every year the more research that's out there and how we're moving forward. So thank you, Shana.
Sure.
I am going to share a video from our sponsor, Rhythm Pharmaceuticals, and then we can go ahead and get ready for our next session. Thank you.
The melanocortin-4 receptor, or MC4R pathway, is a key regulator of energy balance and hunger, affecting body weight by controlling food intake and energy expenditure. This pathway involves peripheral fat stores, releasing leptin. In the hypothalamus, leptin activates signaling of the MC4R pathway by binding to leptin receptors, or LEP-R. This stimulates production of pro-opiomelanocortin, or POMC, which is cleaved by proprotein convertase 1,3, the enzyme encoded by the gene PCSK1, to generate melanocortin signaling molecules, including melanocyte-stimulating hormone, or MSH. Ultimately, MSH activates melanocortin-4 receptors, reducing appetite and increasing energy expenditure. Signaling through the MC4R pathway may become impaired when rare gene variants occur in key genes upstream of MC4R. Such variants may arise in genes encoding LEP-R and POMC, as well as more than 30 additional genes. Impaired function of this pathway can disrupt energy balance and lead to rare MC4R pathway diseases, which are characterized by persistent hyperphagia or insatiable hunger, and early onset severe obesity, defined as a body mass index well above average early in childhood. More prevalent genetic testing is needed to diagnose and manage rare MC4R pathway diseases in individuals with hyperphagia and early onset severe obesity.
And with that, we thank you to Dr. McCormack, and we thank our sponsors for this day, Consonance and Rhythm Pharmaceuticals, and we invite you to take a short break, and we'll see you at the top of the hour in our endocrine panel. Thank you so much.